Hello, hello, everybody. Looks like we got some great attendees here. We've got quite a few of you on. Thank you so much for joining us. I'm the producer for Texas Fertility Center, and I am so happy to introduce Dr. Kaylen Silverberg. He's going to be covering about a lot of topics on IVF today. So I'm going to go ahead and bring him on, everybody. This is Dr. Kaylen Silverberg.
Hi. That's great. It looks like it's working very well. So I just want to welcome everybody. I'm so excited we have so many people doing this or joining into this webinar. This is our first in a series of webinars. So you're going to have to excuse if we have any technical glitches. Hopefully we won't, but if we do, I want to thank Brandy a lot. She's been really doing a lot of work to put all this together. I also want to thank Amy Hall, who's also been responsible for helping us get this together. And I want to tell you right up front that if I say anything that's incorrect or if we have a glitch, it's clearly their fault. So anyway, thank you so much for joining and for taking the time to join us. A little bit of information about this series. This is our first webinar. We're going to have a series of webinars where we're going to be doing these programs every 2 weeks. Each one is going to be focused on a different fertility-related topic. So tonight we're going to talk about IVF. Do I need IVF? What does IVF do? What are the benefits? Our next seminar is going to be about the fertility evaluation. It's going to occur on August 13th at 6:30 p.m. We're going to send an email out tomorrow with the registration link in case you'd like to sign up, along with a quick survey form so that you can comment on the webinar tonight. I know that my chair is broken. I know that I'm going to slip and get a little shorter as the webinar goes. So every now and then, I'm just going to raise my chair like that, so if you cut me some slack. As far as our the educational platform, some of you are patients of TFCs already. Some of you, from what I understand, are not patients of TFCs already. We hope that you will be soon. You may be transitioning into IVF, and if so, I recommend checking out our new educational platform. So on our website, txfertility.com, we actually have an educational platform, and we also have an Ivf Orientation. So prior to COVID, if we all can remember back that far, prior to COVID, we used to host an IVF seminar once every month. And so on a Tuesday night, people would all come to North Austin Medical Center. We'd have anywhere from 50 to 150 people show up. They didn't show up for the food, but they did show up for the 2-hour dog and pony show. So we would have one of our physicians there who would go through slides. We would also have one of the embryologists from Ovulation who would go through slides, and we would talk all about IVF. Well, now we have made modules, and we've put that up on our educational platform. So if you have time, if you would check out our new educational platform, you can click on the IVF education course. It goes into a whole lot more depth than what we're going to be able to cover tonight. And it also includes a link to sign up for that in tomorrow's email so that you'll be able to get that and you'll be able to sign into that as well if you would like to. So let me just give you a little bit of housekeeping. I'm going to go through some housekeeping details here about how the webinar is going to work. Before we get started, just know that I'm going to be stopping to answer questions in the middle and at the end of this. You can submit a question at any point in time. There's a question tab on the side of your screen. I'm going to try to get to as many questions as I can in the time that we have allotted, but I may not be able to get through to all of them. Please keep in mind, I can't answer questions that reference personal situations. In Texas, we're not allowed to give advice, medical advice over a seminar like this, so the more general, the better. And so with that, without further ado, I think I'm going to go ahead and jump right into this. So the first thing that I'm going to talk about is what are fertility issues that IVF can treat? And the answer is, in the old days, I started doing this a long time ago, 25 years ago. And 25 years ago, really, we only did IVF for tubal factor infertility. That's what IVF was developed for. It was developed as a treatment for women who had blocked fallopian tubes. So the concept was really simple. In order for a couple to get pregnant naturally, when a woman ovulates, that egg comes out of the ovary, it gets picked up by the fallopian tube, and it starts traveling down the fallopian tube to the uterus. A couple then has sex, sperm get deposited into the vagina. Some of the sperm, maybe 10%, swim up through the cervix into the uterine cavity, and maybe 1 to 2% of those actually make it out into the fallopian tube. Sperm and egg come into contact with each other in the fallopian tube. You get fertilization in the fallopian tube, and then that embryo travels down the fallopian tube into the uterus where it attaches. And implantation occurs. Typically, ovulation occurs, and then implantation typically occurs about a week or so after ovulation. Well, in women, in cases where the fallopian tube is blocked, what we would do is we would be able to pick up the egg from the ovary, take the egg out, fertilize it in the laboratory, and then put an embryo back into the uterus. And so that's really what IVF was developed to do, and that is treat fallopian tube factor. And it's still, the perfect treatment for tubal factor infertility. But now we use IVF for a variety of different things, because originally IVF only succeeded about 10% of the time. And now, as we'll get to in just a little while, when we do Pgt, when we do pre-implantation genetic testing, and we know that we're putting in a single embryo that is chromosomally normal, we know that couples will be able to have a chance for having a baby of somewhere between 55 and 65, maybe even 70%, depending on other factors, with the transfer of a single euploid blastocyst. So it's remarkable how successful IVF has become. So because of that, we're using it for other things. So women who have ovulatory dysfunction, in the old days, we would just treat people who didn't ovulate regularly with Clomid. And then along came Femara, and we would use Femara. There are also the injectable fertility drugs that we can use. But some patients, either it's too risky to give those drugs, and I'll explain that in just a second, or those drugs don't work very well. In certain people, they don't. And so one thing that we do is we can give these, when we have patients who hyper-respond. In other words, if we give them, for example, Gonal-F or Follistim or Minipure, and they start making eggs, sometimes they make too many big follicles. And we're worried that if we go through with that cycle, their risk of twins or triplets, or God forbid, more than triplets, could be significant. And so what we then do is we can talk to those patients about, bypassing the injections and IUI, and let's go right to in vitro fertilization. Because with IVF, if we make 5, 10, 15 mature eggs, it's not a problem. We don't have to worry about a multiple pregnancy, because in fact, patients don't get pregnant in their IVF cycle. We don't put in an embryo during the IVF cycle. So the IVF cycle is really broken up into two parts now. There is the IVF stimulation cycle, where we give medicines, fertility drugs, patients make those eggs. We then take those eggs out. And then after that, when we go to the lab and we get fertilization and division, we then freeze those good quality embryos. And in the next cycle, we put in an embryo. And we can talk about that a little later. So we can do IVF then for tubal factor infertility, for ovulatory dysfunction, then male factor. We have to talk about male factor because in the old days, guys had to have relatively normal sperm to be able to do in vitro fertilization. But then along came a procedure called Icsi. ICSI stands for intracytoplasmic sperm injection. In other words, we can pick up a single sperm with a microscopic needle and actually inject that sperm directly into the egg to get fertilization. And remarkably, our embryologists are so good that we get typically between 75 and 80% fertilization rates. So if you make 10 eggs, 12 eggs, you should expect that we should have 8, 9, maybe even 10 of those eggs to fertilize with Icsi. It's really an amazing technology. So that opened up IVF now to couples with male factor infertility. We also can do IVF for a variation of tubal factor, and that's a couple, or that's in a woman who has significant scar tissue around her fallopian tubes. So she either had an old infection, gonorrhea, chlamydia, some type of pelvic inflammatory disease, or she has maybe severe endometriosis that can cause a lot of scar tissue formation also. Or maybe she had a ruptured appendix when she was a kid even. And they went in to take out her appendix, but her appendix had ruptured. She formed an abscess in her abdomen, and that caused scarring around her fallopian tubes. So for any of those reasons, IVF is really the best treatment because we can get the eggs out, fertilize them, put an embryo in, and not have to rely on the fallopian tube. So that's really the issue of what fertility issues or conditions can IVF treat. In addition to those, there is a condition called unexplained infertility. And these are couples who come in, we do a fertility evaluation, and we can't find anything wrong. So we do the basic steps that we'll talk about in a minute. We do the Hsg to evaluate the uterine cavity and the fallopian tube, and it's normal. We document ovulation. We look at male factor. We do a semen analysis. We do all kinds of other testing, and everything turns out to be fine. I just want to make sure I'm not getting a notice here. Okay, it says my video is disabled. I'm assuming that my video is back on. Let me just say yes.
Correct. Your video is back on now.
Okay, perfect. Okay, thank you. I don't know why it was disabled, but anyway, thanks, Brandy. But anyway, so even with unexplained infertility, in vitro fertilization is a very effective, very good treatment. So the next issue I'd like to talk about is how do we transition into IVF? Ordinarily, there's this stepwise protocol that most fertility specialists around the world follow. So if we have a couple who comes in and they go through an evaluation, and let me take a chance to talk about this evaluation now. What does the evaluation include? The evaluation typically includes an Hsg, a hysterosalpingogram, and that's an X-ray where we or a radiologist can inject dye through the cervix into the uterine cavity and out into the fallopian tubes. And what that test will tell us is, number one, is the uterine cavity normal? Does it have a normal shape? Does it have a normal size? Are there things in the uterine cavity that shouldn't be there, like polyps or fibroid tumors or scar tissue? And then that Hsg also tells us about the status of the fallopian tubes, because as the dye goes into the uterus, it then flows out the fallopian tubes, and we can make sure that the caliber of the tubes is normal. We can make sure that the tubes are open. And all of those things are very important factors. Another test that we do, typically we draw blood on a woman on the 3rd day of her menstrual cycle. We send that blood off for evaluation of 3 hormones. We look at FSH, which is follicle stimulating hormone. We look at estradiol, and we look at a hormone called AMH. So AMH, I'll tackle that one first. AMH is probably the most important of those 3 hormones. AMH stands for anti-Mullerian hormone. Doesn't matter, don't get hung up on the name. That's what it stands for. We just call it AMH. AMH is a hormone made by the immature follicles in the ovary. So the more follicles a woman has, the higher her AMH. The fewer follicles a woman has as she gets older, as she gets closer to menopause, or if, God forbid, an ovary's been removed or has been diseased, her number of eggs is going to fall, and her AMH level is going to fall concordantly. What we want is, we want for an AMH level on day 3 to be above 0.7, preferably above 1. So if the AMH level, the higher the AMH level, the more eggs a woman has. And there's no direct one-to-one correlation. But to give you some background under the heading of Life's Not Fair, guys make sperm all day, every day, from the time they go through puberty until death. Women, on the other hand, make all the eggs they're ever going to have when they're fetuses in their mother's uterus. So I tell my patients all the time, you probably don't remember, but 20 weeks before you were delivered, you had all the eggs you were ever going to have. You had 15 to 20 million eggs. By the time you were born, 20 weeks later, that number was down to 6 to 7 million eggs. By the time you go through puberty, that number is down to 300,000 to 500,000. And by the time you're 40, you have 10,000 eggs or less left. So egg attrition is a major problem. There's nothing that can stop that, but there are things that can make it worse. For example, cigarette smoking. You may go to menopause 3 to 5 years earlier if you're a cigarette smoker. So it's just another reason not to smoke cigarettes. God forbid you have a mass in your ovary and one of your ovaries get removed. You've lost half your egg supply. Okay, so if you eliminate the drama and the hysteria and just do the math, by the time a woman is 40, she has gone through 99.9% of her eggs. And this is unfortunately not a save the best for last kind of game. And that's why it's important that we know how many eggs we have to work with, because that may cause us to want to progress to IVF even sooner. So another thing about going to IVF is that, sometimes we use non-medical diagnoses or non-medical decisions and inputs to make decisions about what to do in medicine. So for example, if a woman gets married a little later in life and she comes to see me now at 38 years of age and she wants 2 or 3 kids, well, if I use Clomid or Femara or the injectable drugs with IUI and she gets pregnant and has a baby, fabulous. But by the time she delivers and finishes breastfeeding and comes back to see me, now she's going to be 40 or 41. And so now we're working with eggs that are profoundly older, and that's a real problem. So a lot of situations now, and a lot of couples who come to see me, if the woman is a little older, they'll want to jump right to IVF because she wants to get those eggs out when she's 36, 37, 38, make embryos, bank those embryos, because then if we transfer a single embryo into her uterus at 37 and she has a baby at 38, she breastfeeds, she comes back to see us at 39, we can still use an embryo that was obtained from her 36-year-old egg and still give her essentially the exact same chance for pregnancy at 40 or 41 or 42 as she would have had at 36. So I hope that makes sense. Other testing that we do a semen analysis, obviously, to figure out where we are from a male perspective. We document ovulation. Okay, so one easy way, a quick, easy, free way to document ovulation, if you have regular cycles, your periods come on 26 to 30 days or so. You know, you don't have to worry. I've got women who come in to see me all the time who say, oh my God, my periods are so irregular. Sometimes they're 27 days, sometimes they're 29 or 30 days. And I stop them and I say, whoa, that's normal. That's really great. So not every woman has a 28-day cycle. It doesn't work that way. In fact, in my experience, very few people have regular 28-day cycles. So if you have regular cycles, 26 to 30 days or so, 32 days, you have breast swelling and tenderness before your period starts. You have maybe a little cramping, not debilitating cramping, but a little cramping when your period starts. You can pretty much take it to the bank that you're ovulating regularly. I'm getting another message here. Okay, so the next issue is the other things we do for documenting for the fertility evaluation. We do what's called genetic carrier screening. And so with carrier screening, we're going to draw blood from both members of a couple, and we're going to be able to test for the 288 most common genetic disorders that occur in pregnancy. And then we also give patients antibiotics. It's recommended by the American Society for Reproductive Medicine. So I've got some questions that have already come in, so let me take a look at those. So one question, can an HSG check for scar tissue? The answer is yes. So if you have scarring in your fallopian tubes, if the tubes are damaged, if the tubes are blocked, we'll be able to detect that with an HSG. Now, a fallopian tube, I'm going to give you an example here. Assume that my chest is the uterus, and assume that my arm is the fallopian tube. When fallopian tubes get blocked, they typically get blocked in one of two places. They can get blocked proximally, where the tube joins the uterus, or they can block distally, where the finger-like projections are that pick up the egg from the ovary. And this is called proximal tubal obstruction. This is called distal tubal obstruction. Sometimes it occurs from different things or different reasons. So an HSG will detect not only if the tube is blocked, but where in fact the tube is blocked. The next question is, can an HSG detect cysts? The answer is no. The HSG only looks at the uterine cavity and the fallopian tubes themselves. Ultrasound looks at the ovaries, and ultrasound looks at the wall of the uterus. Okay, so the HSG and the ultrasound together give us a much more complete picture of what's going on anatomically. So again, just to review, the HSG can only see the inside of the fallopian tubes and the inside of the uterine cavity. It can't see the ovaries and can't see the wall of the uterus. The ultrasound can only see the ovaries and the uterus. It can't see the inside of the fallopian tube. So we use both those tests together. Last question, I had a normal HSG, but I'm curious about getting a hysteroscopy done. So one person would say, well, why do a hysteroscopy if your HSG is normal? The answer is, if we look at data, and at Texas Fertility, we are data driven. So if you look at the data in couples who have failed an IVF cycle with a normal HSG, if they then undergo hysteroscopy, there is about a 50% chance that the pathology will be there. A little polyp, scar tissue, something like that. So it can still make sense to do a hysteroscopy even in the face of a normal HSG. Okay, other questions. What are protocols? Some protocols as far as medications go for IVF. We have a lot of different protocols that we use. So first of all, we give gonadotropins. We use either Gonal-F or Follistim or Menopur. Most of us use combinations of either Gonal-F and Menopur or Follistim and Menopur. And the reason we do that is because Gonal-F and Follistim are very, very pure concentrations of just FSH. And they're very pure because they're made from recombinant DNA technology. Menopur is much less pure. It's made from a combination, it's made from human urine, and it includes a combination of both FSH and LH. So what Menopur does is it drives LH to cause estrogen production to occur. So when we use protocols with just Gonal-F or Follistim, we'll still get really good eggs to develop, really good pregnancy rates, but estrogen levels are a little lower. And there's been a controversy in our literature for over 20 years now. Should you use just FSH products alone, or should you use a combination product with a little bit of LH in it as well? Most of the studies that have looked at it show no difference. So most studies that have looked at this scientifically show pregnancy rates are really the same, whether you use Gonal-F or Follistim alone, or whether you use them in combination with Menopur. More recently, there are a couple of smaller studies that suggest that maybe you can get a little higher pregnancy rate with a combination of Menopur, and that's why most of us now do use combination therapy. There are other combinations, or there are other ways to stimulate women, so that when we, sometimes you can go to programs where they do minimal stimulation or natural cycle IVF. We don't do that, again, and it's based on data. So when you use natural cycle IVF or even minimal stimulation IVF, the chance for pregnancy is going to be substantially lower. And yet the cost is not going to be significantly different. So all this is related to what I tell my patients is called the IVF funnel. So let me walk you through, I'm going to use my hands here when I speak, but let me walk you through the funnel. When we start off stimulating patients, our average patient is going to get about 12 eggs from retrieval, okay? Out of those, about 75% or 9 should fertilize. Out of those, about 40%, let's say 4, should become what we call freeze-quality blastocysts. If we then freeze those embryos, but before we freeze them, we biopsy those blastocysts to determine if that embryo is genetically or chromosomally normal or not, based on a woman's age, anywhere from 50 to 95% of those beautiful embryos that we biopsy are going to be chromosomally abnormal. So let's assume you're in the best prognostic group. Let's assume you're a woman 35 years of age or younger. Okay, there's a 50% chance that any embryo that we biopsy is going to be chromosomally abnormal. So now what we get is we've gone from starting off with 12 eggs down to 1 or 2 chromosomally normal embryos. And that is a great IVF cycle, because that 1 or 2 embryo is those 1 or 2 embryos that are chromosomally normal are going to give you a 60 to maybe 70% chance of having a baby. Now think about it. The wider the top of the funnel, the more likely more good things are going to come out of the bottom. The narrower the top of the funnel, we may not even make it to the bottom. So let me explain to you what I mean. What if we start off with 20 eggs? If you use those same percentages, now the odds are pretty good that we're going to get 3 or 4, maybe even 5 chromosomally normal embryos. But on the other hand, if the funnel is narrow, a woman is 42 when she comes in, we may only get 4 eggs and 75% fertilized. Now we got 3 fertilized eggs. 40% of those become a blastocyst. Now we're down to 1. And at 42, there's, a 10% chance that's going to be chromosomally normal. So the odds are very high, 90% or so, that we're not going to get any chromosomally normal embryos to transfer. And that's why IVF is far less successful as women get older. Okay, the next question, let's see. How affordable is IVF treatment? Oh, and I'm sorry, the affordable question sparked my memory. So when I say that minimal stimulation is not that much less expensive than maximal stimulation, what I mean by that is most of those expenses are still incurred. So even if you go through a minimal stimulation protocol, you still have to be monitored. There's still an egg retrieval. There's still a surgery center fee. There's still an anesthesiologist, unless you're really brave, to be able to provide you anesthesia. And then there's still the IVF laboratory fees. So what you're going to save, which is not insignificant, but what you're going to save is the cost of some of the medications. So what I tell patients typically, an IVF cycle at Texas Fertility, the average IVF cycle, and every cycle is different, but the average cycle is going to run about $14,000. And out of that, $4,000 or so is drugs. Okay, about $4,000 to $5,000 is the IVF lab. Okay, so now we're at what, $8,000 to $9,000, and then we have $1,600. That's the surgery center. So now we're at about $10,500. The anesthesiologist about $500. Now we're at about $11,000. What am I leaving out? I know the physicians are about $2,000. That's about $13,000. The labs, when we send you off to CPL, are going to cost several $100s as well. So we're running close to about $14,000. If we add genetic testing to that, that's about another $4,500 or so dollars. So IVF for the average patient is going to cost about $14,000, maybe $15,000 for a regular cycle, and about $19,000 to $20,000 if we do genetic testing, if we do Pgta. So that answers the IVF affordability question. Let's see, how successful is IVF? We've talked about that. At what point do you recommend the switch from IUI to IVF? Great question. So in the old days, we would recommend, based on literature, we would recommend doing 6 cycles of whatever it was that you were doing before you went on to the next step. So we would do, for example, 6 cycles of Clomid or 6 cycles of Femara before we would go into the injectable drugs. Why would we recommend 6? It wasn't an answer that we just pulled out of thin air. Studies were done, and if you look at what's called life table analysis, where you have the cumulative chance for pregnancy on the y-axis and the number of cycles on the x-axis, the graph looks like this. In other words, the cumulative chance for pregnancy keeps going up, and once you hit 6 cycles, it levels out at 60%. So what I mean by that is within 6 cycles of Clomid or Femara, 60% of patients are going to get pregnant. No matter how much longer you do Clomid or Femara, there is only a 5% chance lifetime that you will get pregnant. So most of the patients we see who come in from their OB-GYNs have had 2 or 3 cycles of Clomid, they haven't gotten pregnant, and then they're referred on to see us. Sometimes we see patients who've been through 10, 15 cycles, and that's unfortunate because their chance for pregnancy is going to be really low. So next question, does it cost to store unused embryos after an IVF cycle? Yes, it does. Ovation, the IVF lab company that we work with, has a long-term storage facility in Henderson, Nevada, just outside Las Vegas. They will store your embryos. The cost is $500 a year. For male factor, what's considered a viable male sperm count? What we like to get is we like to get a sperm concentration. A normal semen analysis is 20 million sperm per cc of semen or more. 50% of those sperm should be alive and swimming, and 15% should have a normal shape. Okay, and I'm going to jump now from questions. I'm going to get back to the presentation. I will get back to questions again in just a little bit, but I do want to make sure that we can cover the rest of this. So what do you expect during the IVF process? So I'd like to just kind of walk you through it a little bit. I'm going to assume that we've already done all the pre-testing that I talk about. I'm going to assume that we've already made the decision to proceed to IVF. We've already had the conversation about risks and benefits and alternatives, and we can cover those separately if you have questions. So there are several different protocols that we use. The most common protocols, there are 2 major most common protocols that we use. One of them is what we call our Lupron overlap protocol. This is where patients go on birth control pills for a cycle. And they go on birth control pills, not because we've forgotten that they're trying to get pregnant, we understand that, but birth control pills cause eggs to line up at the starting gate. So it's like if you go to a horse race, the horses just don't walk on the track and start running. If they did, the first horse on the track would always win. So what happens is the horses come out on the track and they walk around the track and they line up at the starting gate. And then when the race is ready to start, they fire the gun, they sound the alarm, they open the gate, and they're off and running. And all the horses start running together. Well, birth control pills really have that same kind of effect, because if we started stimulating you without some kind of priming, the data show that we get fewer eggs. So we like to prime your cycle in the cycle before IVF by either giving you birth control pills or by giving you estrogen pills or something along those lines to get those eggs to line up. So the 2 most common protocols we use, one is the Lupron overlap protocol. So typically you would go on birth control pills or some kind of priming regimen. And then about 5 to 7 days before the end of that priming regimen, we would start you on a drug called Lupron. Lupron works on the pituitary gland, a little pea-sized gland that lives behind your nose. It turns off the pituitary gland to block you from ovulating spontaneously. So about 5 days later, you go ahead and you have a period. Then we start the stimulation. So you start taking, in addition to Lupron, you'll start taking either Gonal-F or Follistim and typically Menopur. So most patients on the routine protocols will take about 3 injections a day. They'll do this for 8 to 14 days. During that 8 to 14 day period of stimulation, we're going to be seeing them in the office about every 3 days or so for a vaginal ultrasound to measure their follicles and count the number of follicles we have, and for a blood estrogen level. And so once those 2 things have been done, every 3 days, we'll be able to put that information together and make a recommendation as to what the patient should do for the next 3 days. So we may adjust the dose of medicine, we may titrate to try and make sure that what we're going to get at the end of the day is a really good number of large or mature follicles. We don't want to get too few, we don't want to get too many, because that raises the risk of something called hyperstimulation syndrome. Once we have achieved follicular maturity, so once you've taken your injections for 8 to 14 days, you've come in for your ultrasounds, you've come in for your blood estrogen levels, and we've determined that you're ready to be triggered. In other words, we're going to get the optimal number for you in that cycle of mature eggs. We will give you an injection of another medicine, and the medicine that we use is typically called HCG. And there's several different brand names for that HCG, but we use Novarel, Pregnel, we use the HCG. We know that if you disappeared into the Amazon, 36 to 44 hours after you took that HCG injection, you'd start to ovulate. And we don't want you to ovulate spontaneously. So therefore, what we do is exactly 36 hours after that HCG trigger, we schedule you to go over to Austin Fertility Surgery Center. There is a board-certified anesthesiologist there, not a nurse anesthetist, but a board-certified anesthesiologist. They will give you sedation for about 8 to 12 minutes. We will put you on the operating room table, do a vaginal ultrasound, pass a needle alongside that vaginal probe through the top of the vagina directly into the ovaries and remove the eggs. That whole thing lasts, like I said, 8 to 10, maybe 12 minutes. You wake up in the recovery room. So we then wheel you back from the operating room into the recovery room. You wake up there. In about 20 or 30 minutes, you're pretty close to back to normal. We'll get your partner to drive you back home. We don't want you to drive. Meanwhile, while we have those eggs, what we do is we get sperm from your partner or from a donor. About 5 hours or so after we have those eggs out, we add sperm to the egg, or we pick up a single sperm with a microscopic needle and do Icsi, where we inject that sperm directly into the egg. Then we put those eggs and the sperm that they're going to fertilize them into the incubator, and we wait overnight. So 18 hours later, after we've added sperm to the eggs, we take that suspension out of the incubator and we look under a microscope, and we can see how many eggs have fertilized normally, how many eggs have not fertilized at all, and how many eggs may have actually fertilized abnormally with maybe more than one sperm. And we know that those embryos, those early embryos, then are chromosomally abnormal, and we don't use those. We then put those embryos back into an incubator, and we watch them for 6 or 7 days. We take them out after 5 days, and we look under the microscope to see if they've reached the expanded blastocyst stage. Once they reach that expanded blastocyst stage, we know that there is a significant likelihood that we have a viable embryo. So we will either freeze that embryo at 320 degrees below zero, or we will drill a hole in that outer membrane around that embryo, and we will remove 3 to 5 cells from that embryo. And at the time we do that, that embryo should have about 128 or so cells in it. So by taking 3 to 5 cells out of that embryo, we freeze the embryo at 300 degrees below zero, we freeze the cells at 320 degrees below zero, we ship the cells off to a testing facility, typically one of the facilities we have in either Las Vegas or in Nashville. And then about 5 to 7 days later, we get a report. And that report says, hey, we received 4 beautiful quality embryos, or cells from 4 beautiful quality embryos on this patient, patient A. And embryo number 1 is a normal female. Embryo 2 is a normal male. Embryo number 3 is a female with Down syndrome. Embryo number 4 is a male with an extra chromosome 6. So we know that that's not compatible with life, so we would discard that embryo with the extra chromosome 6. There's never been a baby born alive that survived with trisomy 6. So that's the end of the retrieval cycle. You have a period approximately 2 weeks after your retrieval. When you have a period, you call us up and we line you up for a frozen embryo transfer cycle. The frozen embryo transfer cycle is much more simple than the retrieval cycle. Basically, with the frozen embryo transfer cycle, we will stimulate you either with estrogen pills or with Femara. In rare cases, we won't stimulate you with any medicine. We'll use a natural cycle. And even more rare cases, we'll use an injectable fertility drug like Gonal-f or Follistim. And we only use that in patients in whom we have significant difficulty making your uterine lining thick. So you'll take those, let's say, for example, you take estrogen pills. You'll take those in a very specific format for about 2 weeks. After 2 weeks, we see you in the office for a vaginal ultrasound. We measure your thickness of your uterine lining. We want that thickness to be at least 7 millimeters thick. And if your lining is at least 7 millimeters thick, we know that you're ready to go and your uterine lining is ready. So we then start you on progesterone. And typically, we would do your embryo transfer, where we would typically only put in 1 embryo. Certainly, if those embryos were chromosomally tested, we would only put in 1 euploid embryo, 1 chromosomally normal embryo. And we would typically do that 6 days after you start progesterone. Now, if you have failed a transfer before, or if you only have 1 embryo to transfer, your doctor may talk to you about doing something called an ERA, which stands for endometrial receptivity assay. So very smart guys, friends of ours in Barcelona, Spain, developed this test where they can look at over 200 proteins that are made by the uterine lining. And they identified a subset of these proteins that change during a successful pregnancy. Some are upregulated, which means they're made in a higher concentration. Some are downregulated, which means they're made in a lower concentration. If we do this stimulation cycle, but instead of putting an embryo in on the 6th day of progesterone, instead we take a little piece of tissue out, we can ship that tissue off to one of their testing labs in Barcelona, preferably, or they've got a new lab in Miami. And about a week to 10 days later, they will send us back a report and they will say 6 days of progesterone is the exact right time to put an embryo into this patient. Or it may say your lining is pre-receptive and you may need 7 days. Or maybe you've got too much progesterone, you may need 5 days. So this allows us once again to optimize the time of the embryo transfer. And then we further sub-optimize it by actually looking at the embryo that we're going to transfer and potentially adjusting your day of transfer by 1/2 to 1 full day based on the stage of development that your embryo achieved when it was frozen. So it's very complicated. I hate to walk you through this in 5 minutes here and expect you to understand it. Your physician will walk you through it much more slowly. More importantly, your nurses, who are spectacular, will walk you through it very slowly as well so you'll understand. So then, let's say you've done your ERA cycle, let's say you've done your prep cycle, you're ready to go with the frozen embryo transfer. We would do the exact same thing. We put you on progesterone. When you're ready to be to start your progesterone, we would start that. We would put you on estrogen. Excuse me. You would have a period. We would start you on estrogen for 2 weeks, just like we did in the simulation cycle. Once your lining is at least 7 millimeters thick, then we start you on progesterone. And we would then plan on doing the embryo transfer on day 6 of progesterone if you haven't had a biopsy, or if your ERA biopsy confirms that day 6 is correct, or day 7 or maybe day 5. And again, maybe we'll fine tune that by adjusting it for the stage of development for the actual embryo that we're going to put in. And everything that we do during your entire IVF cycle is optimized around you. So we will look at your situation. We'll look at your age, your AMH level, your FSH level, your reprosource score. Everything that we know about you will help us determine the right protocol to put you on, the right dose of medication to use. But then we don't just rely on that. We still see you back every 2 to 3 days during the stimulation process to make sure we can continue to optimize your stimulation based on your estrogen level and also based on your number of follicles that you're developing and the rate at which you're developing. So that's how we do the frozen embryo transfer cycle. Once we've started your progesterone and we know the day to do the actual transfer, we take you back to the operating room. There is no sedation that goes on there. We'll give you a Valium, but the Valium is not to sedate you. Valium was actually developed as a smooth muscle relaxant. And so we give the Valium to relax your uterus so that we can go ahead and put that embryo into your uterine cavity. We really want to get in and get out of your uterine cavity with that catheter without your uterus even knowing that we were there. And so that's how that goes. We then wait 9 days. And after 9 days, we go ahead and we do the pregnancy test. So I'm going to take another break here and go to some more questions. Can I do IVF if I've had a tubal ligation and I'm 39 years of age? Absolutely. IVF is really the only treatment that's available to you because you've had a tubal ligation. It doesn't make sense at 39 to go ahead and put your fallopian tubes back together because we know that you're still 39 at the end of the day. If the operation works, and it works about 60% of the time, so in other words, about 60% of the time after a tubal reversal, your fallopian tube will still be open at a year out after surgery. But even still at that time, you're still 39 years of age. In other words, based on what I said earlier, your eggs are 40. So you're probably going to want to consider doing IVF. Okay, for male factor, what is considered viable male sperm count? Is that we talked about that. Is there anything that can help to increase the sperm count? Yes, there are a lot of things that can help. One thing that we will do is we will ask if we've got a guy who's got a low sperm count, we'll ask him to go get his blood drawn. And we'll look at his hormones, FSH, LH, and testosterone. And we published a couple of studies, Dr. Vaughn and I did, that looked at guys who had high FSH levels compared to low FSH levels, and they all had low testosterone levels. And what we determined was that in a significant percentage of patients, over 50% of the time, if a guy had a low sperm count and a low testosterone level, we would be able to treat him medically so that we could raise his sperm count enough that he was able to successfully cause a pregnancy without IVF. So there are things that we can do to increase the sperm count. We also tell guys, just as far as lifestyle factors go, if they're smoking, please stop smoking. If they're drinking alcohol in excess, they want to stop that as well. Okay, can you please touch base on when women can do IVF, what the percentage rate of a positive pregnancy is, test is if somebody went through a tubal ligation. So going through the tubal ligation doesn't change your chance for pregnancy with IVF. So you have the exact same chance for pregnancy at your age and your AMH level, whether or not you've ever had a tubal ligation or a tubal reversal. Using a sperm donor, can a woman get pregnant with an IUI, or is IVF needed? Great question. Absolutely. Using a sperm donor, assuming that your tubes are open, you should be able to get pregnant, reasonable likelihood, with a sperm donor. Now, the chance for pregnancy with sperm donation, just like IUI itself, depends upon other factors. So it depends on how old you are. The older you are, the lower the chance for pregnancy. So let's just talk real quick about a 35-year-old woman. So if we have a 35-year-old woman, she's using no medication. She's just using her own cycle. And she's monitoring it using an ovulation prediction kit. So she tests on day 10, 11, 12, 13, nothing. All of a sudden, day 14, she gets a smiley face. She calls our office. She comes in the day after that smiley face, because women ovulate, 95% of women ovulate within 24 hours after that smiley face. She comes in and we do an IUI. Her chance for pregnancy in a natural cycle with no medication is about 6 to 10%. If that woman is 40, her chance for pregnancy is about 3 to 5% per cycle. Now let's say we add pills. We add either Clomid or we add Femara. That 35-year-old who does a Clomid IUI cycle or a Femara IUI cycle has about an 8 to 12% chance, maybe in a couple of studies as high as 15%. All right? If that same woman is 40 or 41 years old, her chance for pregnancy is about half that. Now let's say we go with the injectable fertility drugs. We use the injectable drugs with IUI. Again, at 35, your chance for successful pregnancy is about 25, maybe as high as 30% per cycle. If you're 40, your chance for pregnancy is no greater than about 15% per cycle. Now, if we go to in vitro fertilization and we get a euploid blastocyst, in other words, a chromosomally normal embryo to put in, your chance of a successful pregnancy is somewhere between 55 and maybe as high as 70%, regardless of your age. Okay, so why is that? And the answer is that unlike IUI treatment, excuse me, I got to raise my chair again. Unlike IUI treatment, when we do in vitro fertilization, chromosomal normalcy of that blastocyst trumps everything else. So in other words, a 40-year-old woman with a single euploid blastocyst, a single chromosomally normal embryo, should have the same chance for pregnancy essentially as a 30-year-old woman. So Pgt, this is why we love Pgt, because Pgt really allows us to almost overcome age factors. Now, what's the problem with my logic here? Well, the problem is that I said at the very beginning, you have to assume if we have one chromosomally normal embryo. And the problem is the older a woman becomes, the less likely we are, unfortunately, to get that chromosomally normal embryo. So yes, if a 42-year-old woman produces a chromosomally normal embryo, her chance of having a baby is the same as a 35-year-old. But unfortunately, a 42-year-old has a much lower likelihood of being able to produce even one single chromosomally normal blastocyst. And that's why age is so important. How many IVF cycles does it take for a successful pregnancy on average? Again, it just depends. It depends on lots of different issues. How old is the woman? What's the sperm quality? Is the uterine cavity normal? You know, if I can tell you that, does she do Pgt or does she not? If I tell you using Pgt, you can count on maybe a 55 to maybe as high as a 70% chance of having a baby with one embryo transferred, okay? If you're 42 and you have a euploid blastocyst, maybe the same thing. But if we don't do Pgt testing, there's a profound difference in the chance of having a baby. So if you are 35 years of age or younger, and we don't do genetic testing, so we don't know if that embryo that we're going to put in or not is chromosomally normal, now your chance of having a baby with one embryo being put in is about probably 45%, maybe as high as 50%. If you're 42, now your percent chance of having a baby is maybe 10%. If we're lucky, maybe as high as 15%. So it really depends. So therefore, to answer the question, how many IVF cycles does it take to produce a pregnancy? Well, if you're under 35, or if we're putting in a chromosomally normal blastocyst, it may just take one cycle, and 55 to 70% of those people are pregnant. In 2 cycles, probably closer to 85 or so % of people are pregnant. But if you're 42 and we don't have a tested embryo, it may take you 5, 6, 7 cycles if you get pregnant at all to be able to get pregnant with IVF. So I hope that answers that question. Thoughts on taking prednisone while pregnant for antiphospholipid antibody syndrome? If you are demonstrated to have a specific abnormality, like antiphospholipid antibody syndrome, and your hematologist wants you on, typically they put you on Lovenox, not prednisone, but if they put you on a blood thinner, because the major factor for the antiphospholipid antibody syndrome, the major place it interferes with pregnancy is that it can cause microvascular blood clots, very small blood clots, to form in the small blood vessels of the placenta. So if that happens, we would want to put you on a blood thinner to prevent those blood clots from forming. Some people use prednisone for other types of autoimmune diseases, and that's fine. You can absolutely take it. Some people have severe asthma. They've got to be on prednisone for that. Some people have lupus, and they've got to be on prednisone for that. Absolutely, prednisone is safe to take. Are there any long-term side effects of IVF if a woman has to go for more than one cycle? And the answer is no. There is a very large study. In fact, there are a series of big studies where women have been followed who took these injectable fertility drugs. Now, you've got to remember, these injectable fertility drugs have been around since the 1970s. So these drugs have been around literally for almost 50 years. So if there were long-term side effects from taking these medications, we would know it by now. Of all of the studies that have published, and the big risk, when I say if there was a problem, the big problem that we've all been concerned about from the very beginning is ovarian cancer. Because we are overstimulating the ovaries, we're causing multiple ovulations to occur, either naturally, women ovulate, or with IVF, we go in and we remove the egg from the ovary. And so of all the studies that have been done looking at that, there is only one study published by a group of women at Stanford. Alice Whitmore was the lead author. And she published a study that showed that women who took injectable fertility drugs had a small but statistically significantly increased risk of cancer developing in their ovaries. Now, when those exact same women, Whitmore and Smith, when they followed those patients out further, because remember I said those were preliminary results, when they followed those patients further, the data, the difference in those two groups disappeared. So to my knowledge, I am not aware of a single study, a large, well-designed study, that shows that injectable fertility drugs increase your risk of ovarian cancer. So we believe that these drugs are safe. Let me see, the next question. Trying to follow these here. Is there an increased risk of implantation being successful if you use previously frozen embryos? Yes, we believe that that's the case. So Bruce Shapiro, one of our Ovation partners in Las Vegas, did a very elegant series of studies, and he actually compared the results of transferring embryos that were transferred fresh to embryos that were transferred frozen. And what he found was that when you transferred embryos frozen, there were significant differences in 3 basic parameters. Number one, when you use frozen embryos, there were fewer births of babies that weighed under 1,500 grams. It's a very small baby. There were also statistically significantly fewer births in babies that weighed under 2,500 grams. And there was also a statistically significant difference in what we call morbidity and mortality in the first 12 months of life. So in other words, babies that were born from frozen embryo transfer were healthier than babies that were born after fresh embryo transfer. So yes, we use frozen embryo transfer almost exclusively now. How long does it take for the priming and birth control? Typically, if you've got very good ovarian reserve, you've got a very high AMH, we'll give you birth control pills for 1 cycle. If we do priming, we typically start estrogen priming 7 days after ovulation. So you're on estrogen pills for about 7 days. Causes of painful ovulation, I'm going to skip that because it's not for IVF. Once IVF is done, once we decide IVF is what a patient wants to do, will all appointments be scheduled in advance for the IVF cycle, or will it be as the treatment goes? No, we can't. We would love to be able to schedule everything in advance. It makes our schedules a lot easier, makes your schedules a lot easier. But again, we're individualizing everything for everybody. So you're gonna have to bear with or put up with a little bit of kind of flying by the seat of our pants as far as when your next appointment is going to be. Once you start stimulation, you can pretty much take it as gospel that we'll see you every 2 to 3 days.
Dr. Silverberg,
yes.
I'm so sorry to interrupt, but let's go ahead. We've got so many amazing questions, and you've answered so many. Let's go ahead and skip back to the topics, and then we can answer a few more of them at the end.
Okay, terrific. Okay, well, we talked about pregnancy rates and live birth rates associated with IVF with and without Pgt. So again, first of all, what is Pgt? Pgt is pre-implantation genetic testing. There's 3 types of Pgt, but I'm only going to talk about one because the other 2 types are very rare. Well, I'm going to talk about Pgta, which stands for pre-implantation genetic testing for aneuploidy. Aneuploidy means any embryo that has any number of chromosomes other than 46. So all embryos that are normal should have 46 chromosomes. If you have an extra number 21, that's called trisomy, or a third copy. Trisomy 21, that's Down syndrome. If you have an embryo that has 1 too few chromosomes, for example, you're missing an X, so now you only have 45 chromosomes, that's a condition called Turner syndrome. Okay, so Pgt typically is done because it allows us to identify those embryos that are chromosomally normal. And we know from our studies and from lots of other studies that have been published in the literature that when we transfer a single chromosomally normal embryo, there is a much higher likelihood of success, a successful pregnancy. So really, that's the end of my presentation. What I'm going to do is I'm going to go take some more questions. Can a woman continue working while going through treatment? Absolutely. We just ask you really to be a little bit careful as far as limiting activity. You can do pretty much whatever you want during IVF stimulation. So we have a lot of patients who work out a lot, and it's fine to continue to work out during your IVF stimulation. I tell my patients that your ovaries are going to tell you when you need to slow down or when you need to stop. It's fine to have sex during IVF. I would ask you to avoid having intercourse once your biggest follicle gets to be about 15 or 16 millimeters, because we've got to have your partner be able to bank up some good quality sperm. If you have sex the night before a retrieval, the odds of getting good sperm goes down, which is obviously not what we want. Using a sperm donor, can a woman get pregnant with IUI or is IVF needed? We talked about that, yes. How many IUIs are needed for a successful pregnancy? Again, we do typically 6 cycles, up to 6 cycles, and that's where the pregnancy rates maximize and level out. I am turning 40 at the end of the year. I'm overweight. Is it still a good idea to follow through with IVF? That's a good question. It's a tough question. We obviously like for all of our patients to be as close to their ideal body weights as possible. And the reason is information that Dr. Vaughn and I published several years ago. And what we determined was that women, the more overweight or the more above a woman's ideal body weight she actually was, the more medication she took. And so that raised the cost of an IVF cycle. And that's very important. So the next question, are payments for IVF normally taken before, during, or after treatment? You can talk to our billing people. I'm going to have you give them a call. They can talk to you all about that. They can talk to you about financing options. They can talk about all of those things. Next question, can you do IVF even if your tubes have been tied? Yes, you can. What happens if a patient does not have a normal menstrual cycle during IVF treatment? So what happens is the IVF stimulation regimen is really going to take over your cycle. What we care about is the cycle before IVF. During that cycle, you're either going to be on birth control pills or some kind of priming, or you'll have your own natural cycle so that you will have a regular cycle. What is the average time for most people from once they begin IVF stimulation to successful embryo transfer? So again, if you look at IVF as the stimulation cycle, that's a month. And then the transfer cycle, it's about 2.5 weeks from the time you start priming for your transfer cycle until we put the embryo in. And so then there's 9 days after that until we do the pregnancy test. So what if I already have frozen eggs? What is the process of going from frozen eggs to prepared embryos for the transfer? Great question. Lots and lots of our patients have frozen eggs. We have frozen them because, God forbid, they were sick. They were going through medical treatment, chemotherapy, radiation, surgery, something, or just prolonged medications that potentially were toxic to embryos. If that's the case, once you're ready to go, we can thaw those embryos, add sperm either from your partner or from a donor to make embryos. We thaw those eggs, add sperm to make embryos. And then it's just like the regular old IVF process. I am 45. Is there still a chance with IVF? There is, but I can tell you the oldest patient I've ever had successfully have a baby with their own eggs with IVF was 46. She came in a long time ago with her 64-year-old husband. It took her 6 cycles of IVF, but eventually she did get pregnant and have a baby that was normal. Does PCOS lower the chance of successful IVF? It does. PCOS is a challenging condition. We want to make sure we get it under control as good as possible or as much as possible prior to simulating you. So we may ask you to go on metformin. We may put you on some other medications in order to be able to try and get the PCOS under control as much as possible before we start. What is the chance for a natural pregnancy if one tube is blocked and the other is open? That depends on where you ovulate. So if you ovulate from the side in which you've got an open tube, you still would have the same chance for pregnancy as somebody who ovulates on either side and has 2 open tubes, depending upon that treatment. So if it's a natural cycle with IUI, your chance for success would be 6 to 10%. Clomid IUI would be about 8 to 12%. Injectables and IUI would be about 25%, depending upon your age. Can we pick the gender in the transfer month if, in fact, you have both sexes? So if you have female embryos and male embryos that are chromosomally normal, absolutely, you can pick which one you want, and you can pick the order. You can also pick the transfer month, of course, if we do frozen embryo transfer.
Dr. Silverberg, let's go ahead and do about 3 to 4 more questions, and then go ahead and wrap it up.
Absolutely. Okay, if you are having unprotected sex, currently, is there a certain time frame to start looking into infertility options after no luck in getting pregnant? Does this depend on age? That's the exact right question to ask. So the definition of infertility, if a woman is under the age of 35, is no pregnancy within 12 months of attempted conception without contraception. Okay? If a woman is over 35, it's 6 months. And what that highlights is that the chance for pregnancy as you get older goes down. So it's very important that we factor that in. Let's see, is it possible to predict aneuploidy of embryos for the same couple based on previous Pgta results? The answer is no, it's not. Great question. If, God forbid, you've gone through IVF before, you've done Pgt, and you have no chromosomally normal embryos, assuming that your chromosomes are normal and your partners are normal, you still have the same chance as baseline of having a chromosomally normal embryo. Can a 26-year-old woman get pregnant with sperm donor with IUI? Absolutely. How many? Up to 6. Single or double embryo transfer, am I able to choose to transfer 2 embryos? No, you're not. We're very strict about that. We follow the Society for Assisted Reproductive Technology guidelines. I was actually on the committee that participated in developing those guidelines, and we looked at all of the data, and what we did was we designed a process and a recommendation in order to maximize the chance for pregnancy while minimizing the risk of multiple pregnancy. So therefore, if a woman is 35 years of age or younger, we typically only transfer 1 embryo. If, as she gets older, we can transfer more than 1. If she has failed 2 transfers, regardless of her age, we can add another embryo to put in. And if we do Pgt, regardless of her age, we only put in 1 embryo at a time. Again, because of the data that I talked about before, the studies I talked about before, this suggests that Pgt is the great equalizer. Okay, last question. Do you ever transfer more than 1 embryo in a cycle? Does it increase the chance? So we talked about that a minute ago. The answer is no, we typically don't transfer more than 1 embryo in a cycle. Does it increase the chance for success? We actually did a prospective cycle, or prospective study, in which we went to patients who were all under the age of 35, and they all had at least 2 normal embryos for transfer. Half of those patients we transferred 1 embryo, half those patients we transferred 2. And what we found was the chance for pregnancy was not statistically significantly different. But in the women who only transferred 1 embryo, we had no multiple pregnancies. And in the group of women in whom we transferred 2 embryos, we had a 51% risk, or 51% incidence of twins. So therefore, I can tell you that we can give you pretty much the same chance for pregnancy just by doing Pgt. That really, if you put in a euploid blastocyst, it's really just as good as if you put in 2. So I am so grateful for you sticking it out and being here for this presentation. I want to thank you very much for participating in our first webinar. Thanks for going through the glitches and for tolerating my droning on and on. I hope you found this information valuable. If IVF is something you're considering, please feel free to schedule a visit with us. We are doing virtual visits. So if you're concerned about COVID, we are doing virtual visits. If you want to come into the office, we're happy to see you in the office as well. Or alternatively, we're going to be hosting another webinar in 2 weeks. We hope to see you there. We will include a link to register for that tomorrow as well when that goes out. Once again, I want to thank Brandy Shea for her tremendous work on this presentation. She really made everything very, very easy and brought all of you into the room so that we could actually do this webinar. I also want to thank Amy Hall, who came up with this idea. Very grateful to her for so many things. And so thank you all so much for joining us tonight. I hope you have a great rest of the night. Stay safe, wear your masks, and wherever you go, anywhere. I tell everybody who comes in contact with me, I tell them from the minute you wake up in the morning until the minute you go to sleep at night, if you're out of your house or if you're around other people in your house who are not relatives, or if you are out and about, or unless you're in your own home or in your own office with the door closed and nobody else is in there, or you're eating, please wear a mask. Don't touch your face, and we'll all get through this together. So thank you so much for joining us. I hope you have a great night, and we are so happy to have you at Texas Fertility.